new approach. We practice for at least 15 years with a lot of success, but for many doctors it's a new approach. We use it for severe lumbar spinal stenosis only, and the complex endoscopic decompression of severe central canal stenosis should be reserved for the most experienced surgeons. I think you have at least 100 to 200 endoscopic surgeons first. The first limitation, the technical complexity. It's a small working area and need a high-speed endoscopic power instrument. Higher complication rates were published recently. In this article, the author had a renewed interest in revisiting the safe transforaminal approach and how to be modified to decompress the severe central canal stenosis. Here, as you can see, do you have the pointer here? Yeah, as you can see, you get the traditional interlaminar approach, and we are dealing with this approach, Trans-Facet approach. You need to know, it's better always if you do the decompression, have a CT scan and MRI. I recommend the CT scan and MRI always, and you're going to do this approach. It's similar to the transforaminal approach, but you're going through the articular. The classic transforaminal, interlaminar, transforaminal, we are going to Trans-Facet. Choose the right approach. We are dealing all the time in endoscopic approach. You try to get the door, to open the door, but that is the right approach. You need protocols to get the solutions. You always talk interlaminar, transforaminal, what? You need experience, surgeon experience. We published in 2019, we published select protocols. This is a guide for you. You can read it, and it's not the ultimate things, but I think you need protocols to reach your problem in endoscopic surgery. These protocols, we put this, and we classify the stenosis in 1, 2, 3, 4, and we choose the protocol. Then we always use anesthesia, local anesthesia and sedation. We published this article with the professor and with Kai and the professor Joe Abrao, anesthesiology of the University of San Pablo. Which is the goal? Is a subtotal or total resection of symptomatic facet. Transforaminal may lead to incomplete decompression with transforaminal in a central stenosis. Interlaminar may be associated with high rate of durotomy and bleedings. The key step consists of entering the facet joint space. We call egg-shelling out for a total decompression. Access the spine via posterolateral approach, guide wire into the joint with fluoroscopy. Also in the experienced hand, you can use progressive manual drills and begin decompression. We have a cohort of 65 patients, claudication symptom with severe central spinal stenosis, follow up over 2 years, approaching the most symptomatic site, unilateral 56, bilateral 9, and we use a standard protocol for bias in the bilateral side. An inclusion, clinical sign, imaging evidence, successful non-operative treatment, age 35 to 85. Exclusion, segmental instability greater than grade 1 in spondylolisthesis, infection, metastasis. This is the anatomy. As you can see here, this is the articular process. This is the facet. And you need to know with the CT scan the right orientation, because to put your UKY inside here. This is the fast. You go to decompress, and then you can reach very well both sides of the compression in a central stenosis. Okay. We are with the patient awake. In this case, it's a failed back surgery. We endoscopically broke the bar, as you can see here in the X-ray. With the drill, the titanium one. Sorry. And we are going to go through the facet, and we open over the top, and first with the YAPI and second with the CAP. Many times I use the Tom Shitty for open the facet. You need a lot of experience because the radiculitis, I prefer with the patient awake always. I always operate with the patient awake. But you can start with that. Open to 6 or 8 millimeters, depend the case, you see? And then you can see from outside, sorry, with the drill. Patient is awake, you can speak with the patient. It's the drill, high speed drill with a lot of torque. Don't worry about the RPM, worry about the torque of the drill. And here inside, like an egg, you see, you reach the spinal canal. It's similar to the egg. Then you start open the YAPI first, the inferior, and then the superior facet. When you do a lot of endoscopy, it's a very fast decompression, and you reach both sides very fast. And safety. You are very lateral. You have very poor, very decreasing problem with durotomy. No, not durotomy. It's difficult to get a durotomy here, especially this case with previous surgery. There, you decompress. You need more open the YAPI here and go to the other side. And you finish with both sides and a good decompression. The author disseminated survived 793 potential surgeon participant a link during ESASS, sponsored Zoom April 2024. And the result is 2029 access the power webinar survive was 154 starting, it and 119. Completion rate 75%, this quarter of respondents. Consider painful low-grade lumbar degenerative spondylolisthesis and appropriate indication for endoscopic decompression of lumbar and spondylolisthesis being associated with favorable clinical outcome with a shift of the mean logic location for the right above the one logic, suggesting greater than 75% endorsement. That's the result. And discussion. Comprehensive decompression of central stenosis or multifactorial stenosis involving both central and lateral recess or foraminal zones may be limited due to restricted visibility and access to a specific anatomical structure, especially in excessive calcification, hypertrophy of osteophytes. There is the potential for residual or recurrent stenosis, mainly when a substantial facet joint resection is needed. The author proposed the Trans-Facet technique as a safer and effective way to remove large amount of bony soft tissue stenosis. Our data show that the procedure is effective and reliable, reduce pain, and improve patient functioning as corroborated by the favorable clinical outcome in 87.5% of the patient. With excellent and good MAGNAV outcome, the Trans-Facet approach is conductive, a low-risk decompression in a spinal canal central and lateral aspect, thereby addressing multi-compartment stenosis with enhanced precision and efficacy. Our series observed no duotomy, only 7.5% of patients suffering from postoperative transitory dysesthesia, from irritation at the surgical level. Postoperative instability was not observed. This is the myth. This is new. We have to deal with this now. What about instability? Always facetectomy and instability. What about this? The survive, talking about the surgeon don't believe in this, in instability. In these cases. And
Dr. Dowling, please summarize. Please summarize.
Okay, we finish. Thank you.